My name is Andrew Sauer, one of the associate editors with the Journal of Cardiac Failure, and we're really excited to have a conversation today with Dr. Michael Felker. And he's going to talk with us a little bit about the editor's pick. Specifically, we're going to talk about the Target HFDM study, which is out in press this month in the Journal of Cardiac Failure. Welcome, Mike. Appreciate you joining us today. And maybe you could begin by just talking with us a little bit about the context, sort of the impetus to how this concept was conceived to study this question, and what was kind of the specific hypothesis that led to you and the investigators going forward with this study.
Well, first, thank you, Andrew. It's great to be here, and thanks for the opportunity. We were really interested in how you could leverage sort of patient-facing or commercial tools that are out there, like text messaging and step counters that many people are wearing these days, to try to change health behaviors in vulnerable populations. And so the population we focused on, as you said, was in patients who had heart failure and diabetes. We really wanted to see, could we impact two really important health behaviors? One, physical activity, because we know sedentary lifestyle is a big, both a risk factor for heart failure and diabetes, and also a marker of worse outcome, and also medication adherence, because I think increasingly both those disease states are characterized by very complex medical regimens, can be a lot of challenges for patients. So we really wanted to see if we could leverage sort of commercial grade patient-facing technology to try to improve those health behaviors and hopefully impact clinical outcomes.
Tell us a little bit more about the details of ultimately, how did you decide what endpoints to focus on? How did you decide, for example, to do step counts versus maybe 6-minute walk test, which a lot of folks use as a traditional endpoint?
Great question. So, we really wanted to see, could we improve daily physical activity? And for most of our patients, the main physical activity people have during the day is walking. And step counters are obviously, ubiquitous now. They're on your phone. People wear them on their wrist. And we also wanted to leverage that to not just measure what people were doing, but also to provide sort of ongoing personalized feedback to try to actually see if that could impact how much they did. So basically, everybody in the trial got a step counter and wore a step counter every day. Patients in the intervention group also got 3 times a week texts, which weren't just sort of generic things like you should exercise more, but actually were personalized to how much they had done the week before, setting goals for this week of how many steps per day. The usual care group just got a text message every week saying, don't forget to wear your step counter, but they didn't obviously get any specific encouragement other than being told that exercise is good for you. There was also a medication adherence piece of the intervention, which was basically a teaching session using something called the D3 pill box, which is basically a medication adherence tool that uses teach back and some of those things that we're used to thinking about with teaching our patients to see if it could improve people's adherence with their medications. And then the last thing I'll say is we really wanted to create a very generalizable trial, very pragmatic. So we included people regardless of ejection fraction.
How many people got randomized, and what did the patients look like? How sick were they?
Yeah, so we planned a sample size of 200 patients. Like so much else, our trial was abbreviated a little bit because of COVID. We ended up with just under 190 patients randomized. We had, I think, a pretty typical group of patients with heart failure and diabetes. They were ambulatory, because obviously this was an outpatient intervention. I mean, it was striking. They were quite sedentary at baseline, as you might expect. I think the baseline step count was somewhere just over 3,000 steps a day. So these are not people who are doing a lot of regular exercise, which is ideal, because those are the people you really want to target.
Take us through the meat. So what did we find?
So the intervention lasted for 3 months, and then we turned off the intervention in terms of people stopped getting texts and everything, but we kept track of people's steps for an extra 3 months, because one thing we were interested in was what I'll call stickiness. We all know if you start an exercise program, everybody joins a gym in January, by March, like you're not going as much. And so we really wanted to see if any lifestyle changes that we created, if they persisted once the intervention was turned off. And what we found was, a modest, but I think potentially important improvement in daily steps in the intervention group. It's about a 10% increase in daily steps. That was statistically significant. We did not see a change in the adherence. Some of the other interesting things we found, though, is we actually found improvement in quality of life using the Kansas City Cardiomyopathy Questionnaire at 3 months for the patients enrolled in the intervention compared to usual care. And, pretty intriguing that even maybe what seems like a modest amount of physical activity could have other potential benefits for our patients.
Yeah, one of the things that was really interesting to your point about, so what happens when you sort of take away the intervention after 3 months, so they still had access to their step count, correct me if I'm wrong,
Yeah.
but the alerts went away after 3 months. And what you saw in that figure was that they kind of came back to baseline in terms of their step counts. And I think if I recall, there was a bit of a petering out of their KCCQ markers as well. And they had about a 7-point improvement in KCCQ at the 3 months, and that kind of waned a little bit.
I think what we found is that it's got to be something persistent. It can't just be a short-term intervention if you want to see longer lasting effects.
So just a little minor point here, but I think of interest still. So the metabolite component of the more of an exploratory endpoint, but medium and long chain acylcarnitines. So adherence wasn't really different, but they exercised more in a sense over the 3 months. So what do you make of the finding that there was a significant difference in a reduction in those metabolites in the intervention arm?
We've shown before that people who do exercise training, that and potentially one of the mechanisms of benefit is you develop a more favorable metabolomic profile, and that's also associated with favorable longer term outcomes. And interestingly, even with this relatively modest change in physical activity, 10% increase from a baseline of around 3,000 steps a day, we actually saw favorable changes across the metabolomic profile. So, it may be that if you can change lifestyle, it doesn't have to be a dramatic change to start seeing some actual health benefits, especially in people who start out, like I said, really quite sedentary.
Yeah, so in the greater context, as we kind of wrap things up here, I'm thinking of Prompt HF and Tariq Ahmad presenting that at ACC and sort of thinking about these types of nudges, and especially the ones that aren't necessarily all that expensive.
The way you described it, talking about the nudges, is really important because one really unanswered question is who should you nudge? I mean, is it more effective to nudge clinicians, or is it more effective to nudge patients, or should you be nudging health systems? Like, we know there's huge gaps in implementation of best therapy, whether those are drugs or whether it's lifestyle things. And the question is, how can you make those changes happen? I think we recognize it's a big challenge. I think digital tools can be part of the solution. I do think we have to be careful, though, because I think it's possible that the dependence on digital tools can also increase some gaps we see in terms of equity of the way medical interventions work their way in the population, because obviously there's a lot of differences in access to technology. So I think we have to leverage the tools we have, and technology is one of those tools. I don't think it's a sort of panacea that will fix everything, but I do think it has the opportunity, if used thoughtfully and in a patient-centric way, to hopefully impact some of the things that we know is going to make our patients better.